A very warm welcome to you. I'm Father or Dr. David DeMarco, and I'm a Jesuit priest and a physician, a member of the Stritch faculty and university ministry. And what a pleasure and privilege it is for me to reflect with you today about medicine and spirituality. Medicine and spirituality comprise many different themes. Our focus today, however, is going to be an introduction to spiritual history taking as a way of assessing the role of spirituality in the life of the patient. About 2 decades ago, when I began to reflect on the spiritual history, it was common for me to experience resistance among my physician colleagues to even considering the subject. Over time, I've seen that resistance change to one of embracing the spiritual history as a way of coming to a deeper understanding of the life of the patient and a way of building a more profound trust with a patient. And that profound trust can lead to a whole new way of accompanying a given patient. Medicine and spirituality. Well, welcome. Before we go any further, let me offer you my contact information and feel invited to reach out to me, either by calling me or using my email address or simply coming down to my office in the gathering room for a conversation. I'm always willing to engage around this topic of medicine and spirituality. I want to add at the outset that the lecture you're about to participate in has been revised substantially for the academic year 2022 through 2023. The original lecture has been now divided into 3 lectures, this being the first of those 3. The other 2 pertain more appropriately to the spirituality of the caregiver and the caregiver's reflective practice. This lecture on spiritual history is more pertinent to your patient-centered medicine 1 experience. What I'm going to do is try to provide you with a very practical approach to assessing the role of spirituality in the life of the patient, an approach that ought to work regardless of the patient's faith tradition or perhaps in the context of no faith tradition at all. You might ask about comparative religions and the treatment of death and dying. These are very, very specific topics that are beyond our scope because our approach today is going to be that of offering you a practical way of understanding the role of spirituality in the patient's life and addressing it as the patient sees fit to have it addressed. I want to add as well that all of the scientific studies that I'll be using today are in the bibliography, and the entirety of the bibliography constitutes a list of suggested readings. I'll highlight some, I think, of the most important of those readings for you as we go. Let me add further, before we go any further, that this lecture is not my opinion. It's simply not a reflection of what I think you should know about medicine and spirituality, but it's actually consistent with the recommendations of the Association of American Medical Colleges, otherwise known as the AAMC. In 1999, the AAMC promulgated this statement about medicine and spirituality, noting that students of medicine, student physicians, medical students, will be aware of the need to incorporate awareness of spirituality and cultural beliefs and practices into the care of patients in a variety of clinical contexts. So it's their expectation that medical schools throughout the United States will address medicine and spirituality on some level. Consistent with what the AAMC recommended back in 1999 is a meta-analysis that was concluded just a matter of weeks before this lecture was taped. This meta-analysis from Balboni and colleagues concluded the following, and I'll remind you that a meta-analysis looks at the totality of the literature on a given subject and makes a determination about the quality of that evidence, and then comes to a consensus about that evidence. This meta-analysis concluded that it's vital that medical training should incorporate evidence-based approaches regarding the associations of spiritual community with patient outcomes. That it's vital that medical training increase spiritual awareness among health professionals. That it's vital that medical training recognize spirituality as a social factor associated with health. So this comes from a meta-analysis, and I invite you to review it on your own. It's listed in the bibliography, and it may be among the most important of the references in that bibliography, and certainly among my suggested readings for you. Here are the objectives that we're going to follow. There are 5 of them. They are in question format, and we will transition in this order from an understanding of what is spirituality through the usefulness of spiritual history, the appropriateness of taking one, and the actual approach to taking a spiritual history. We'll conclude with a conversation about the resources that are available to the physician who seeks to spiritually support her, his, or their patient. Well, let's consider this vignette at the outset. Imagine that you're shadowing the clinic, as many of you will soon do if you have not already, when the attending physician with whom you're working asks you to take a spiritual history from a patient who appears profoundly depressed. And mood disorder is often one of those settings where it is quite appropriate in the clinic. It's quite appropriate to take a spiritual history. There would be a great deal of consensus around taking a spiritual history in the setting of serious mood disorder. So the patient asks the attending physician, well, what is spirituality anyway? What is spirituality? How would you respond to that patient's question? What is spirituality? To answer that question, we're going to pause for a moment and consider the concept of the transcendent. The transcendent is that which is beyond myself. It's that backdrop of all human experience that is not only a backdrop of experience, but it's capable of conferring meaning on that experience. For many of your patients, the transcendent is going to be God. That's the name they will give the transcendent, the backdrop of their experience, and that which gives their experience meaning. It may be nature. That could be the transcendent in a patient's life, or it could be the web of human relationships, or it could be something completely other than that. Sometimes the sense of transcendent is implicit. Sometimes it's explicit. That is, sometimes we can give voice to it, sometimes we cannot. But by transcendent, I'm referring to the backdrop of human experience, the horizon of human experience, that is capable of giving my experience, the patient's experience, meaning. Consider these 3 questions. Now, how can I become my best self? This is a question that many of us are asking ourselves on an ongoing basis. Or maybe in the experience of suffering, why? Why is all this happening to me, I may ask, or the patient may ask. How should I relate to myself? You might hear patients asking this. How should I relate to myself and others? These are questions that you may have asked yourself, that I may have asked myself, that your patients may have asked themselves. Note something about these 3 questions, though. Each of them is asking about something that is of value beyond themselves, The answer to these questions is not merely a fact, but is a value-laden response. These questions are pointing to the transcendent, that which is beyond myself, that forms a backdrop of my experience and is capable of offering or conferring meaning. So we might begin to weave this together and conclude spirituality to be the contours or the lines of my relationship with or connection to the transcendent. And I engage in this relationship or connection with the transcendent. I engage my spirituality in order to find meaning in the midst of experience. And so my spirituality actually becomes a portal to meaning. Again, spirituality describes the contours of my relationship with or connection to that which is beyond me. And I engage this relationship or connection. I engage my spirituality in order to find meaning in the midst of experience, such that spirituality becomes a portal for meaning. Let's take an example of what I'm referring to. Imagine a crisis. In the midst of a crisis, I turn to the transcendent, which may be God, as it is for many of your patients. God is not, of course, the only conception of transcendent, but it's the common. God would be a common conception of the transcendent. So in the midst of crisis, I turn to the transcendent. I may turn to God. And as I do that, as I make that turn, I engage my spirituality, which is a particular way of relating to the transcendent, a particular way of connecting to God in this instance. And so through my spirituality, I begin to find meaning in crisis. In crisis, I find meaning. So in the midst of crisis, I quite naturally turn to the transcendent. And as I do that, I engage the transcendent through my spirituality, a particular understanding of connecting. And all of this is in service of finding meaning in the midst of experience, especially in the midst of crisis. Now, important to take a step back and look at three terms: spirituality, religion, and faith, because often they're used interchangeably, but strictly speaking, they are not interchangeable. It's important to clarify the meanings. When you hear these three words used, what you want to do at the outset is ask the individual using them to clarify what each of them means for you. But strictly speaking, they do not mean the same. We've identified spirituality as the way of connecting, or a way of connecting to the transcendent, however the transcendent is understood. It's that way of connecting in order to find meaning in experience. Religion and faith are related to spirituality, but they're not identical with it. Strictly speaking, religion refers to an organized set of community-endorsed beliefs and codes and practices. Sometimes a religion will give rise to a spirituality, but religion is a very organized set of communal endorsed beliefs, codes, and practices. Faith is an even more fluid term than religion, because faith can sometimes be used as a synonym for religion, or it can be used as a synonym for belief in the transcendent, or even the strength of that belief. It's not uncommon in certain traditions to hear someone say that a particular person is a person of faith, or a person of great faith. So faith tends to be a very, very fluid term. Religion less so. Again, these both refer to things that are related to spirituality, but not perfectly synonymous with spirituality. And so to summarize, what is spirituality? Spirituality is the way we relate to the transcendent. It's the way we relate to that which is the backdrop of our experience. And we relate to the transcendent in an effort to find meaning in the midst of all of our experiences, but especially the most significant or the most traumatic. This is a picture of Bear Butte in extreme southwestern South Dakota. Some of you may have had a chance to visit the Black Hills. It's very near the northern edge of the Black Hills, a sacred space for the Lakota Sioux, as well as other Plains tribes. You can see the prayer claws tied to the trees here, which represent the fact that a member of the tribe has come to this place and offered a prayer and has memorialized that prayer with a cloth. Bear Butte has long been a place, certainly among the Oglala Lakota, where the vision quest is often held, a kind of special retreat that's typical of Native American religion among the Oglala Lakota. Well, let's take up another vignette. Imagine that you're shadowing a hospice and palliative care attending on inpatient rounds. And between patient visits, she turns to you and asks you, well, why do you think taking a spiritual history is even useful? Why do you think spiritual history taking is useful? How would you respond to that? Why is a spiritual history useful? We're going to step back in time, in fact, to the Second World War and the life of Viktor Frankl. Viktor Frankl was an Austrian psychiatrist, Jewish, who was imprisoned in 4 different concentration camps by the Nazi regime. And in each of those camps, he witnessed the death of a close family member. He survived, and in the late 1940s, he wrote A Man's Search for Meaning about his experience in the death camp. And this quote is at the heart of his work. Man is not destroyed by suffering, but rather by suffering without meaning. Frankl understood that human beings need to live meaningfully. They need to live meaningfully. And this brings us back to the spiritual history. The spiritual history is useful because it tells a physician something about the patient's search for meaning, especially in the midst of illness and suffering. The spiritual history will offer a physician a window into how the patient seeks meaning in the midst of suffering. Remember that spirituality is ultimately about finding meaning by turning toward the transcendent in the midst of suffering, in the midst of an experience of one kind or another, often suffering in medicine. So Frankl is reminding us that there's something very human, essentially human, about seeking meaning in our experience. And so the spiritual history will offer a physician a window into how that patient finds meaning in the midst of suffering and illness. It's easier for a patient to find meaning in the midst of suffering if the physician who's accompanying that patient appreciates the spiritual dimension of human experience and inquires about it. And this is where it's really important for you to examine your own interior landscape as a student physician and ask yourself, what do I notice about my own response to this idea of taking the spiritual history? Do I find resistance within myself, or do I embrace it and look forward to doing it and what it can offer me as far as accompanying a patient in a richer way? The reason it's important for you to note your own resistance or acceptance of the spiritual history is because it's going to influence how you appreciate the spiritual dimension of the patient's life. For example, if you find the whole idea of medicine and spirituality to be off-putting, then that will almost certainly color your willingness to inquire about a patient's spiritual life or to appreciate it on any level or any level at all. So you want to really examine your own interior landscape and note how you yourself respond to the notion of medicine and spirituality having anything to say to one another. If a physician understands a patient's spirituality, then they understand something about how that patient seeks meaning. And if a physician understands a patient's spirituality, they can empower patients' meaning-making and healing in some ways that they might not otherwise be able to do. But I think there's more to the spiritual history than just these two. I think there's a question about prognosis here that we don't want to neglect. And this is where we begin to look into the scientific the scientific literature regarding medicine and spirituality. A study from 1998 demonstrated that data from religious commitment and health status, a review of the research and implications for family medicine, data published in the Archives of Family Medicine in 1998 suggests that religious commitment may play a beneficial role in not only preventing illness, but improving one's ability to cope with it and facilitating recovery. So we begin to see that there's a connection between spirituality and health outcomes. Interestingly, however, there seems to be a divergence between a patient's attitude about spirituality, or patients' attitudes about it generally, and physicians' attitudes. And what do I mean by that? What do I mean by a divergence between patients' attitudes and physicians' attitudes with regard to spiritual history taking? Well, consider this study from 1999, published in the Annals of Internal Medicine. It demonstrated that 66% of patients in this study were open to having a physician inquire about spirituality, and they believed it would actually strengthen the physician-patient relationship. On the other hand, only 15% recalled ever being asked by a physician about their spirituality. So on the one hand, you have patients suggesting that this would be helpful, that a spiritual history would be helpful, and on the other hand, you really don't have physicians harmonizing with those patient desires. There is a divergence in attitude here. Consider another study. This was published in the Annals of Family Medicine in 2004. 921 responders, patients in a family medicine clinic, participated, and 83% of them, that's almost all of them, wanted spiritual issues addressed in at least some circumstances. Were open to having a spiritual history taken. Now, in a clinical setting, I will tell you, I've never been asked about my spirituality. No one has ever taken my spiritual history. And you might ask yourself, has anyone ever taken your spiritual history? Have you ever had your spiritual history taken? This, although it's anecdotal, underscores that divergence between what patients desire and what physicians actually are offering. So why is a spiritual history useful, if we could summarize? Because it promotes relationship. It strengthens the physician-patient relationship. And it can empower healing in some new ways. And it seems to have prognostic value. There seems to be a connection between spirituality, a patient's spirituality, the depth of that spirituality, and their ability to cope with illness, and maybe their ability to recover from it. Well, we press on to the third vignette. So imagine you're shadowing in the Access to Care clinic, which is the clinic where I often work, and you hear an attending ask the resident, the internal medicine resident, about a patient's spiritual history, about a dimension of the patient's spiritual history. The resident seems surprised with the question, and he asks the attending, well, when should I be taking a spiritual? When do you take a spiritual history? Is it always appropriate to do it, or is it just sometimes appropriate? How would you respond to this question? When is it appropriate to take a spiritual history? Well, consider these three vignettes and ask yourself, would you take a spiritual history? Imagine a 24-year-old woman who comes to the clinic, well-established patient, with symptoms consistent with a urinary tract infection. Would you take a spiritual history in that setting? Would you take a spiritual history from a 45-year-old man who is presenting with what seems like major depressive disorder? Would you take a spiritual history in that setting? How about a 30-year-old woman who presents to the clinic for the first time to establish care? Would you take a spiritual history in that context? When is it appropriate to take a spiritual history? A helpful axiom is this: the greater the patient's need to find meaning in the midst of their experience, often again suffering, the greater that need, the more appropriate the setting for taking a spiritual history, with one exception, and that is when a patient's establishing care. There's consensus around taking a spiritual history with the first encounter as a way of getting to know more thoroughly this patient who's new to your practice. So these would be the two settings when it's appropriate to take a spiritual history. And this is actually supported by data in this study from the Annals of Family Medicine in 2004. You can see that patients are open to discussing spirituality. They're open to you taking a spiritual history in the setting of serious illness. Almost everyone. When they're admitted to the hospital. Almost everyone. If they're experiencing chronic pain. Certainly a majority of patients. Or if it's the initial visit, you can see that 60% of patients were open on the initial visit to spiritual history taking. However, when it's a minor concern in a patient who's already established, most patients don't really resonate with a spiritual history for a minor concern, acute cystitis, acute pharyngitis, and the like. In my practice, spiritual history taking is often done in the setting of mood disorders. We have a large number of patients who are wrestling with major depressive disorder or generalized anxiety disorder or a combination of both, and it's often in that very stressful setting that I find myself taking a spiritual history and have never experienced any resistance to that in this particular setting. So to summarize, when is it appropriate to take a spiritual history? In the setting of crisis. In the setting of crisis, significant illness, or with that first encounter to establish care in the clinic. We all remember how important it is to have good restorative space. Snowshoeing is one of those places that I find good restorative space. Remember to cultivate whatever that path is for you as you move through these 4 years of medical school. Let's take up our fourth vignette. Imagine you're shadowing again in the clinic, and the last patient of the day is new to your attending's practice. And so the attending naturally turns to you and asks you to do the spiritual history. You take the history. How do you do that? How do you proceed? How do you take a spiritual history? Well, on the first visit, what I want to suggest is that the spiritual history is going to be part of the psychosocial history. It's going to be embedded in that. However, if the patient is already established, then I typically place the spiritual history in the history of the present illness. That is, as I'm taking, for example, a history of the patient's depressive symptoms, I will simply fold in a question about the spiritual history into that history of the present illness. And then I'll revisit the spiritual history at the end of our encounter in an effort to incorporate it into the patient's therapeutic plan. One helpful way of taking a spiritual history is to use Christina Puchalski's spiritual assessment. I've adapted it to some degree here. It's originally hers. I've highlighted the words that make up this FICA, F-I-C-A acronym. F refers to the question, do you consider yourself a spiritual person at all? That's often the first question. Or how important is your spirituality? That would be a follow-up question. What spiritual community are you a member of? Another follow-up question. Then the final follow-up question is, how would you like me to address your spiritual concerns? Think of the mnemonic acronym FICA, F-I-C-A, adapted from Christina Puchalski's work. And this comes to us from Psychiatric Annals 2006, still used today. My question is often this to patients. This is often the first question that I will ask. What about your spiritual, religious, or faith life? Or the way you find meaning in the midst of your experience? Are you comfortable sharing with me? This is often the first question that I will ask. And then I will follow up. If this is the first visit with the patient, my follow-up question is going to be, how would you like me to support you? If, however, we're in the midst of crisis, my first follow-up question is, could we return to this question at the end of our visit? And when I get to that point, my second follow-up question at the end of the visit is going to be, how would you feel about engaging your spirituality as you navigate this crisis, this disease? How would you feel about finding a way to engage your spirituality? I'm not prescribing prayer. I'm simply asking the patient if there's a way they can engage their spirituality, recruit it as an ally as they're making their way through a difficult time, through a health crisis. In my practice, many patients have immigrated from Mexico. Many of them have around their necks a medal, a medallion, an image of some kind of Our Lady of Guadalupe, which you see here represented. And so often when I'm taking a spiritual history from one of the patients in the Access to Care clinic, I will ask them to describe for me the image that they're wearing around their neck. And often that leads organically into a conversation about their spiritual life and how they use their spirituality to seek meaning in the midst of crisis. And then that leads quite organically to a conversation of how they might engage their spirituality in the midst of this difficult time that they're going through. Other patients you may encounter will have other religious medallions, images around their neck that you can quite naturally ask them about. And that would lead rather organically into a conversation of spirituality and the life of spirituality in the patient's well-being. So how does a physician take a spiritual history? You can use the adapted FICA model as part of the psychosocial history if this is the patient's first visit, or you can embed the spiritual history in the history of the present illness and therapeutic plan, as I do for established patients, especially those who are clearly in the midst of a healthcare crisis. Let's consider our final vignette. After taking your first spiritual history in the community health clinic, which is a clinic where many second-year students typically work, you consider the resources available to you for the spiritual support of the patient. What are some of the resources available to you as the caregiver to support spiritually the patient? What are they? Well, of course, the first spiritual support for the patient can be the physician, you, the caregiver. The second is the patient's spiritual community. And the third would be the spiritual care professionals, the spiritual care chaplains, especially if you're in the hospital or the emergency room, the emergency department. You have access to drawing on the spiritual care chaplains who are in the hospital 24/7, sometimes also in the outpatient clinic. These are the three primary resources that support a patient spiritually. So that when the patient tells you how they would like you to address their spiritual needs, one of these three, or several of them, may be in play. The first resource is, of course, you as the physician. And this is, again, the reason why you want to consider any implicit bias that you might have about medicine and spirituality, especially resistance, because that will determine just how involved you become as a physician in the patient's spiritual history taking. I mean, there is a spectrum of involvement that physicians navigate along. Of course, taking a spiritual history is the first step on that spectrum. Referring a patient to a representative of the patient's spiritual tradition is that next step. And then yet another step on that spectrum of spiritually accompanying a patient would be praying with the patient, praying with patients of the same faith tradition as you have or another tradition. I think there are caveats that we want to consider in accompanying a patient spiritually and answering the question, well, how involved do you get? Most of us will likely be comfortable taking the spiritual history and even referring a patient to a representative of the patient's spiritual tradition. But when it comes to praying with patients, often many of us find that we're resistant at that point. And so there are some caveats, I think, for us to consider. We have to find our level of comfort. We don't want to move beyond what we're really comfortable doing, especially in the area of spiritual accompaniment. With respect to prayer, for example, praying with patients, I know some colleagues who pray with patients. Some of them actually initiate the prayer, and in other instances, they allow the patient to initiate the prayer. With respect to praying with patients, again, you have to find your level of comfort. Is it something you're comfortable doing? I never pray with patients unless I'm invited to do that. It's completely at the patient's initiative, and that's a posture that I would encourage you to inhabit as well. Allow the patient to initiate that. And then in that moment, you have to consider for yourself just how comfortable you are. And even with the patient initiating prayer, you participating. So find your level of comfort. You want to avoid offering premature assurances. You need to avoid saying things like it's going to be all right, because it may not actually predict what's going to happen. So we want to avoid premature assurances. And we want to stay very close to using the kind of active listening that we know builds physician-patient relationship. It permits a physician to hold a patient's experience without needing to fix it or manipulate it. So find your level of comfort, avoid offering premature assurances, and stay very close to active listening when it comes to things spiritual. Set as your goal that of holding a patient's experience, not manipulating it, but rather holding it for them. So what are the resources available for the spiritual support of the patient? Well, of course, the physician, and then the patient's spiritual community, and then the spiritual professionals, the spiritual care staff, which you may have access to. These are the resources available to support the spiritual life of the patient. Let me say a word about the bibliography here. Everything that I have used is curated here. I want to highlight the most recent study, the meta-analysis by Balboni and others, Spirituality in Serious Illness and Health, because it is a meta-analysis. It looks at all of the literature that's been published about medicine and spirituality, especially spiritual history taking, and draws some important conclusions from the empirical data as well as from consensus among some of these authors here listed. So that would be perhaps the most important of these references if you're interested in if you're interested in suggested reading. That would be first and foremost on my list. Well, we have covered a lot of ground today. We've focused on a very practical approach to understanding a patient's spiritual history as a way of assessing the role of spirituality in the patient's life, the role of spirituality and meaning-making in the patient's life. We've looked at it from a number of different perspectives and have concluded that accompanying a patient spiritually, that is, taking a spiritual history, is a way of enriching the physician-patient relationship. It's a way of promoting healing beyond the traditional practice of medicine. And it also offers some information that's prognostically useful. As we've said, spirituality seems to play a role in patient wellness. Well, I'm deeply grateful for you giving me some time to speak with you and reflect with you about spiritual history taking. Feel free to seek me out if you have any questions. Otherwise, know that I wish you the very best as you navigate Patient-Centered Medicine 1 and the rest of your medical career. Have a wonderful rest of day.